And our last speaker for this panel is Dr. Daniel Grace. Daniel Grace is a postdoctoral fellow at the University of British Columbia Faculty of Medicine as part of a CIHR-funded multidisciplinary investigation exploring the use of new HIV testing technologies for early detection and response among gay men in Vancouver. Daniel has a PhD in sociology from the University of Victoria, is a research associate at the Institute for Intersectionality Research and Policy here at Simon Fraser University, and a visiting fellow at the London School of Hygiene and Tropical Medicine. His ongoing research interests include global health, HIV/AIDS, transnational legislative reform processes, and social inequality. Please join me in welcoming Dr. Daniel Grace.
Wonderful, thanks so much, and thank you to the organizers of Beyond Behaviors for providing me with this opportunity. And I'm very honored to be able to present today, especially along such a line of distinguished presenters. So it's my pleasure to present some analysis being conducted by the CIHR team in the study of acute HIV infection in gay men. So among other things, I hope that my remarks will be able to spark some thoughts regarding the need to consider the role of medical technologies in producing new categories of infection and testing protocols in shaping men's understandings of their health. So this is maybe a slightly different angle than how some other people have interpreted the conference theme, and I'm thankful to the organizers for encouraging me to pursue this line of analysis. So in some ways, the presentation today, or the data I'm presenting, will kind of flirt with behavioral and beyond behavioral kinds of data. And I'd like to acknowledge my co-authors on the presentation. This represents the work of a really diverse multi-sectoral team, but any errors I present today or anything that's overly sociologically dense is completely my fault. So don't hold that against anyone else. I really try to keep it pared down, but it is a challenge for me. I'm really working on it. So my presentation today will focus on the use of new HIV diagnostic technologies with gay men in Vancouver. I'll start by providing some context around the enhanced HIV technology that was introduced as part of our study. I'll then briefly review our study methods and present our analysis of participants' narratives about discovering their HIV status. In the discussion and conclusion section, I'll offer some of our team's early reflections on the implications of these findings and delve into some of the questions raised by the theme of this conference. So in short, I hope to open up some discussion for the ways in which the analysis of HIV testing and diagnostic practice must move beyond behavior to consider the contexts in which tests are taken, read, and interpreted in the everyday world. Now, that said, it's important for me to also acknowledge that testing is arguably an important part of our response to HIV, but is woefully inadequate in and of itself. The epidemiological data has already been reviewed, so I need not get into that further right now. So at first, I need to briefly say something about HIV, acute HIV infection. So acute HIV infection corresponds to the first 2 months of HIV infection and is the period associated with high viral loads. This graph here illustrates the fluctuation in viral load over time. Notably, viral load peaks in this acute phase and then naturally drops to significantly lower levels before beginning to increase again. And so this graph, is attempting to illustrate the importance of detecting HIV during this very early or acute phase. The literature varies with respect to how many infections are actually the result of acute infection, ranging somewhere from 11 to close to 50%. So the Health Initiative for Men, one of our community partners, has worked to disseminate information on this stage of infection with bus ads and posters, online advertisements that underscore that HIV is hottest at the start. I was presenting this data in another province in Manitoba, and I had this image, and someone came up to me afterwards, and they were really interested in learning more about acute infection, and they said, wow, that's a really innovative campaign the Health Initiative for Men is doing. Those men hugging really got to it. And I thought, No, they're not hugging. And so that was an interesting thing to work through, that there was, you know, a team of doctors and clinicians who were actually uncomfortable talking about sex, talking about fucking. And so it was interesting to see how that euphemism of hugging got invoked. So our study has introduced enhanced HIV testing technology in Vancouver with the purpose of diagnosing men during the acute HIV infection period, which is not detected by standard HIV tests. We've worked closely with labs and clinicians providing the test prior to implementation. We also work closely with our community partners to educate gay men about this new test. So HIM led this campaign under the slogan, "What are you waiting for?" to promote awareness of NAT tests, which is called the early HIV test. And to date, 25 men who would otherwise not have been given an HIV negative test result, who would have otherwise been given an HIV negative test result, were identified during this early stage of infection and subsequently offered access to enhanced HIV prevention programs, which has been designed in collaboration with community partners. So just something quickly about our study. It began in 2009 and completed a new enrollment of new study participants in June of 2012. This slide is just a snapshot of our study activities, and you'll see these diverse quantitative and qualitative aspects over a year-long period. So you can see the multiple aspects. So today I'm going to be focusing on that first blue box at the bottom, the baseline qualitative analysis with participants. So 25 men were recruited after receiving an acute or recent HIV diagnosis at one of 6 clinical sites in Vancouver. As you saw in the last slide, participants completed a series of self-administered quantitative questionnaires and concurrent qualitative interviews at 4 time points over the year. It's important to note that our earliest participants were among the first people to receive diagnosis via NAT technology, and that there was a learning curve during these first diagnoses, which led to modifications in testing and diagnosis protocols. The majority of our participants lived in Vancouver at the time of study enrollment, identify as gay, which is why I'll be using that language throughout the presentation, are single, over 30, and Caucasian. 12% of our participants are Southeast Asian and 8% Hispanic. Most participants are employed full-time with considerable diversity among those who are not. And most reported completing college or university with the mean income between $30,000 and $50,000. So our findings regarding the diagnosis and discovery process is what I'll be focusing on today. And this really involves 2 interrelated domains of kind of the key areas I'll be quickly reviewing. So one is in relation to how guys came to discover or came to know about their infection with HIV. And so we've got kind of 3 overarching domains I'll quickly review. And the other involves the specific subset of participants, 13, who received an acute infection. So there's really little qualitative research to understand what interpreting the significance of this stage of infection means for participants. What does this mean in terms of how one incorporates HIV into themselves? So this is what we'll be focusing on. It's important to note that other key domains we're reviewing in this cohort as a whole that are beyond the scope of what I'll be presenting today have important cleavages with information that's already been presented, including the work that Dr. Adam presented earlier. So, for example, we have really rich data on the likely infection event that men note, and there's an interesting relationship there between introducing a new technology that shortens the window period between getting a positive result and getting diagnosed, and what that might mean in terms of informing gay men's understandings of when they were actually infected. So to start, participants were motivated to test based on a number of factors. For many participants, their motivations for testing informed their expected results. So this ranges from seroconversion symptoms informing one patient's expectations of the result. Not all participants experienced seroconversion symptoms, but a number of them talked about both why this informed their result and as well as how they accessed other information, other kind of technologically mediated ways of accessing information. So for example, looking on the internet to try to figure out what does this actually mean, and then going and trying to seek a test based on first looking at the internet and trying to go through some sort of process of self-diagnosis. So one of the arguments here is that the discovery and diagnosis of HIV for many of our participants was a process. There wasn't a singular moment in time where they said that is diagnosis, but it was a process of self-diagnosis, which has been reviewed as increasingly being kind of technologically mediated or informed by other kinds of clinical technologies and lay technologies. So this area of data is very rich and includes participants talking about their expected results. So for example, one talking about expecting a negative result because he had tested so many times and had become used to getting a negative result. So most participants received their test results in clinical settings. However, some received a phone call asking them to come in to receive their test results. Some participants indicated that this call signaled to them that they had tested positive. So one participant describes his reaction to receiving a call from a clinician. At that moment, I knew something was wrong. I said, like, you know what, I think I'm positive, most likely. So this was something that we heard over and over again, with participants knowing if I'm called, even just seeing the caller ID from the clinic signal to them that maybe something was wrong, and certainly being told to come into the clinic meant that many were dealing with a degree of self-diagnosis at that time. Others talked about receiving their diagnosis, a minority of participants, over their phone officially, and talked about some of the circumstances in which they were in where they received the results, and that posed some challenges, including this quote of a man who was at work at the time. So men also highlighted the experience of officially learning of their HIV test results and interacting with healthcare providers in clinical settings at the time of diagnosis. And overwhelmingly, participants report receiving really strong support from clinicians. And a number of participants reported being relieved once an official diagnosis was actually given. As this participant said, which will really bridge me into the second section of results, the idea of finally getting a positive diagnosis meant that a game plan, it was time that a game plan was developed that he could follow. And this is where we can turn to this participant who has an acute HIV infection and look at what that game plan actually looked like. So now we can turn to this subset of participants who received an acute diagnosis, and I'm going to be looking at kind of 5 key areas, some of which are related to more individual and intrapersonal kinds of aspects of analysis, and others which are more structural. So the first concerns that a few participants noted that the clinician they were interacting with seemed uncertain to a certain degree about the HIV test results. That there was a degree of confusion and some interpretation issues of the new technology. So I can skip over this quickly, but the point would be that in introducing a new technology, there's a need to further develop and support those interpreting those results. Another area is around uncertainty about acute HIV infection. So some participants were confused about the meaning of acute infection. So participants had varied levels of knowledge about acute infection prior to the diagnosis. Some participants looked up information about acute HIV infection online before they were diagnosed, and others recalled information from the Hottest at the Start campaign that I noted earlier. Yet even at the stage of interview, review, some participants remained uncertain about the meaning of this stage of infection, with a number noting things like, I just wasn't in the right headspace at the time of diagnosis to receive this information. One participant said, I'm not even sure if I was told it, but I just wasn't emotionally able to hear that kind of information during that stage. So another area, and again, this is how participants are interpreting the meaning of acute infection, and a lot of participants interpreted the significance of getting this diagnosis in relation to starting treatment. So being acutely infected led some participants to seek HIV treatment immediately, and in other cases, treatment was initiated by clinicians and really explained as the advantage of detecting acute infection during this stage. Yet some participants remained unclear why they had started treatment so early. So as we can see here, this treatment, that the knowledge of treatment had led this person to associate the drop in viral load with being on treatment. And this is just a kind of side editorial aside at the bottom about the extent to which treatment as prevention may or may not be informing decision making, and that's just kind of a question that I'm still working through, and I'd be happy to discuss. So participants were often told at diagnosis they were highly sexually infectious or knew this information prior. For many participants, the increased risk of transmission impacted their decisions about sex, with many reporting that they had either abstained from sex or limited sex to lower risk activities, such as only oral sex. So one of the things in relation to the conference theme here that we're continuing to think through is this notion of behavioral change post-diagnosis, and maybe the problematic construction of that at times, if it presupposes a particular risk profile at that time. So our participants had varied experiences with sexual risk and very different routes to infection. So I think there may be a danger in assuming a particular risk profile, a very dangerous actor that's very risky that then has to have behavior change. And so maybe we need to talk through that a little bit more. And I think one of the advantages to being able to look at our participants over the year is to see those behavioral changes and over time, and thinking of that in relation to the baseline data. And the final major domain here is in relationship to identity formation. So it appears that the acute diagnosis had very little impact on the ways in which most participants viewed themselves as HIV positive men. So I identified those kind of 4 areas that were clear, and so we weren't really sure how this additional information would get incorporated into the identity, and it seemed to have little, with men saying things like positive is positive or HIV is HIV. So our analysis has examined the everyday uses of new HIV technologies in practice and related testing and diagnosis protocols with gay men. We have shown that new testing protocols have shifted the experience of learning of one's HIV positive serostatus and created a new diagnostic category with varying impact. Participants' perceptions of uncertainty regarding HIV test results among practitioners emphasizes the importance of continued clinician education about the ways in which the body responds virologically and immunologically. I'm just going to, because of time, I'm just going to skip over this a little bit more quickly. So one of the major kind of theoretical thrusts here is about thinking about the ways in which technologies are relational and the ways in which they impact people's understanding of their health in multiple ways. So in our case, this kind of objective study or this NAT test allows us to provide information to people closer to the time in which they seroconverted and while they're still in the acute phase of infection. And it's a technological advance that allows us to identify previously unrecognized stages of infection. But I'd argue that we need to examine the impacts of this new technology and this resulting acute HIV infection diagnostic category we need to examine it in the everyday world with people who use these services and people who get these results. So further, the introduction of a new technology happens in the context of existing technologies for HIV diagnosis and treatment and existing understandings of HIV. So by continuing to examine our participants' experiences with these practices, we can learn about processes and structures in the BC context and move beyond individual behavioral analysis. So the argument really is, how can we move to get to structure? And one of the things that I'm compelled by is the really critical literature in illness experience that really calls on us to move beyond individual kinds of analysis, so something like the role of metaphor, the restructuring of individual patient lives, the structuring and looking at meaning making and coping methods and strategies, which are all really important and all aspects of some of the data that I reviewed. But how can we move from individual patient narratives to understand matters of social structure and institutional coordination? And that's some of what we're thinking through today, and I'm hoping we have a chance to talk a little bit about. And it's this kind of, I'm allowed to say dialectic because Barry said it. So it's this dialectic between individual, the micro level, and structural or the macro level experiences of illness that represents a real challenge, I think, for further investigation. And I find this quote really compelling. The challenge is to define a paradigm and methodology for handling the problems related to the social structure. This entails working out the theories about the interrelations, reciprocal effects, and feedback between subjectivity, cultural factors, and social structure. And so the concluding thoughts from this analysis are really preliminary, and I'm out of time, but I'll say this is kind of a preliminary phase of investigation, and we're working with our clinicians, community partners, and providers to think about what the implications of these data are, as well as other directions for analysis that allow us to move beyond structure. So I guess I'll just end by saying that our findings point to important considerations for public health programs that elect to use new HIV testing technologies such as NAT. Among other things, we are currently considering these overarching objectives. And while testing and treatment are woefully inadequate to address the epidemic among HIV among gay men and the broader determinants of gay men's health, I've tried to explain a few key examples from our preliminary analysis that bring a kind of social lens to these biomedical interventions. So not to create this false dichotomy, but to bring kind of social theory to think about biomedical intervention. So thanks very much. And I'd just like to acknowledge our community partners, research participants.